Good evening. My name is Rachel George, and I'm here to discuss antithrombotics. Antithrombotics work to reduce the formation of the very scary blood clots, and they're actually much scarier in a real person.
A blood clot.
Normally, blood flows through our veins and arteries smoothly, but if a clot or thrombus disrupts the smooth flow of blood, it can result in complications such as a heart attack, stroke, pulmonary embolism, and even death. As providers, we must be knowledgeable regarding the use of antithrombotic medications in the clinical setting. Antithrombotics act by inhibiting platelet function directly or by inhibiting platelet activation and fibrin formation. Antithrombotic drugs include antiplatelets, anticoagulants, and fibrinolytics. Antiplatelet drugs, which inhibit platelet aggregation in the treatment of arterial thrombi, include Agrinox, Plavix, Effient, Brilinta, Ticlid, Pleadol, and aspirin. Anticoagulant drugs, which inhibit formation of fibrin strands, and drugs in this class include Coumadin, heparin, Pradaxa, Xarelto, Eliquis, and Arextra. Anticoagulants are the mainstay of prevention and treatment of venous thromboembolism because fibrin is their predominant component. Fibrinolytics dissolve existing clots by converting plasminogen to plasmin, either in circulation or on the surface of existing thrombin. Fibrinolytic drugs are streptokinase, urokinase, and TPA, which is the most common. Antiplatelet drugs and anticoagulant drugs target each component of clot formation and can be used to prevent thrombogenesis, but have no effect on existing clots other than limiting their progression. Only fibrinolytic drugs can actually dissolve an existing thrombus. Oral antithrombotic drugs are absorbed in the GI tract, distributed by binding with plasma proteins in the blood, metabolized in the liver and kidneys, and excreted in the urine and feces. Use precaution when prescribing antithrombotic medications in patients who are taking other antithrombotic medications, are pregnant or breastfeeding, have a history of GI bleeds, uncontrolled hypertension, bleeding disorders, recent brain, spinal, or diabetic surgeries, diabetic retinopathy, history of hemorrhagic strokes, liver or renal failure. Other than active life-threatening bleeding, there are few contraindications that are found when choosing to use antithrombotic medications. The decision to treat a patient with antithrombotic medication takes into account a patient's risk for thrombosis if not treated, weighted against the risk of bleeding while on antithrombotic medications. A few adverse drug reactions are hemorrhage, thrombocytopenia, skin necrosis, GI discomforts, and hypotension, and anemia. Drug interactions are vitamin K with warfarin, NSAIDs, St. John's wort, and several over-the-counter medications used to treat pain, cold, and GI symptoms. Can alter the absorption or increase risk of bleeding. When determining the best course of treatment for a patient with a DVT, many providers are divided on the first line of treatment. For many years, the first line of treatment for a DVT was heparin, used in the first 3 to 6 days, and then changing to warfarin for 3 to 6 months. However, now several providers use Xarelto 15 milligrams twice a day, taken with food, for the first 21 days, and then Xarelto 20 milligrams taken once daily with food for a minimum of 2 months. Monitoring of a patient on antithrombotic medications could include an INR, PT, or a PTT, depending on the prescribed drug. Several of the newer medications, such as Xarelto, do not require monitoring, making these drugs more appealing to the patients. When you prescribe an antithrombotic medication to a patient, be sure to educate them on the importance of always telling every doctor that they are on a blood thinner and consulting their provider before starting a new medication. Instruct them to call their provider immediately if they experience any of the following: menstrual bleeding heavier than normal, red or brown urine, bowel movements that look like tar, bleeding from gums or nose, vomit that is brown or bright red, productive cough with red sputum, severe head or stomach pain, a fall or bump on the head, dizziness or weakness. Educate the patients on their increased risk for bleeding and the importance of being extra careful when using knives or scissors, to wear non-skid slippers around the house to prevent falls, and be careful trimming their toenails. Instruct them to use electric razors, soft toothbrushes, and wax dental floss. When outdoors, be sure to always wear shoes, wear gloves when using sharp tools or gardening, and avoid activities and sports that can easily cause injury. Avoid drinking alcohol if prescribed warfarin. Avoid foods high in vitamin K. Never skip a dose. And if a dose is skipped, don't double dose. Report for testing is required by your provider because if blood is too thick, a clot could form. And if blood becomes too thin, then bleeding may occur. Patients should also be instructed to wear an alert tag to let others know they are taking a blood thinner during emergency situations where the patient is unable to speak. Treating and monitoring patients recently diagnosed with blood clots can be stressful and scary at times for providers. However, staying up to date on antithrombotic medications make clots no match for us. Not today, blood clots.